That's perfect. Good evening once again. My name is Aaron Shear. I'm the CEO of NoTube, and welcome to our webinar on our telemedical approach. With me tonight is my sister, Dr. Elizabeth Beckenbach, who is our medical doctor and our medical director. And we are very excited to answer your questions. Before we will get to your questions, my sister is going to give you a little overview of our programs at the moment and of our telemedical approach in general. And then we're very excited to hear your questions. Thank you for sending them in. However, it's just much more fun to just talk to each other. So after a little input, we're going to get to talking to each other. Little information, this is being recorded and it's going to be sent to you, the video, and we've already got your okay on that with your getting here. And let's see about the time. I think maybe we're only going to be 40 minutes, but also we'll see we have the full hour. Lily, please.
Hi, good evening. Welcome to our webinar. So my name is Dr. Lily Beckenbach. I'm a pediatrician and I'm also specialized in nutrition and also in palliative care. And I'm the leading pediatrician in the online programs. And I think what probably is the most interesting for you is what to expect. How can one think of how the treatment looks like? And so I would start with a little introduction, and afterwards, I'm really happy to answer all your questions because this is probably also makes more sense for you. So the first step of our treatment is always our medical assessment. And the medical assessment contains or includes that we will ask you to register your child on our platform, which is a secure platform, and we will ask you to upload three videos of your child. Then we will ask you to fill in a questionnaire, a very detailed one, and also we will ask you to upload medical data. And if you complete the assessment, two of our experts will evaluate all the information we get from your child to see first, is your child suitable for our program, which is in 99% the case. And the second important question is which program fits to your child the best. Because we do have now programs answering all different eating problems, behaviors, tube dependency, all the problems there can be in the age of 0 to 10, 12, 13. That's like our main focus. So this is the reason why this takes quite some time also for you as parents. It also costs 180 euros. And then you will get, after a few days, you will get an answer from us. Is your child suitable and to which program we think is the best for your child? So let's talk about the programs we have. We have three main programs I want to introduce today because I think this will probably cover most of the issues parents and children have. It's first the tube dependency. So we have one program called Net Coaching. It's for all children with a tube. And this is a program which can last also a little bit longer, like 3 to 6 months, depending on your child and the progress. And our success rate on this net coaching program is very high. It's even the same as high, over 95%, as compared to the children who visited our eating school in Graz so far. So we have a very high success rate. And I will explain a little bit later how the treatment looks like. So we have the net coaching program for the tube-fed children. Then we have for the young children, meaning 0 to 4, 5, children which sometimes have problems in getting off the bottle, still remain to the solids, having problems with being selective, all kinds of problems which occur like in the age of 0 to 4, 5. We do have a program, a special program, it's called Learn to Eat, which takes 3 months with a every day, I will say that a little bit later, the treatment, how it looks like, but with a daily contact with us. And then the third big program is our new Select Me program. And this is made for all the children with highly selective behavior or an ARFID. So this is like a big spectrum of diagnosis. Maybe one of you heard the word ARFID already. In some countries, it's very common already to say, and in some countries, it's not. It doesn't really matter. We have a specialized program for the little, like, we don't make it five, like the years exactly. So we always will see which program we think suits your child the best. But this is like for the older children. If possible, if your child is already able to also communicate with us and doing Zoom calls or even go in a communication with us, we also offer this as well. So this program is called Select Me. So this is the three big programs, and then we have two other ones which I would only talk about if there are special questions. So we have a tube optimization program and a program for older children with anorexia. And all our programs for you as parents or professionals look similar, kind of. We do use a secure platform where we will communicate on a daily basis. Depending on your program, you will have a Zoom once a week with one specialist, and ideally the same therapist you will have for 3 months in the Learn to Eat and also in the Select Me program. So you have a continuity. But we always work multi-professional. So we're at least 2 or 3 professionals who will give you advice and who will help you in this eating therapy. It's me as a pediatrician, we have a psychologist, and we have special feeding therapists. And we always try to get to know your child very well so that we try to think what's going on and what could help your child the best. And we always are very flexible in making a really individual treatment for your child. So there will be programs with quite a lot of Zooms and informations, and there will be programs like the net coaching where we mostly do asynchronous written communication with you on a daily basis. So if you have a tube-fed child, we will ask you for intake protocol. What does your child get by mouth? What does your child get by tube? What is the weight? So we are very close in contact also on the weekends. So there will be always also a pediatrician in the background so that we really, really supply a very medically supervised tube weaning program for your child, which is very safe. Yes, and so depending on the program, it has a different duration, but what you always get is specialists on the feeding difficulty your child has and very close interaction with us, I think. Okay, and the last thing I want to say is is our therapy based on? So we do have a very long-lasting and experienced concept, which is called the Graz model, which has also been published in scientific papers, which mainly the main, maybe also difference to other programs is that it's child-led. So whatever we do, we always focus on the child and see what does the child need and how can we help optimizing circumstances that the child is able to move forward or make oral progress. So this is like the most important base for all the therapy programs. And on our platform, we will ask you for videos very often because this is the best way for us also to get your child, to understand your child. And then we will give you advice, try this, how did this work? And we are in a very intense communication and written and via Zoom calls. Yeah, I think that's
It's a good start.
the most important. Was it too long or too short?
Just perfect. I want to add one thing about the child-led because it is the thing that makes us unique. And now one could wonder, how do you do child-led with children that don't talk yet because they're so young? And that really is the challenge of our approach and what we also like, because a lot of the programs, they concern themselves with the parents and the parents suffering, who are very much suffering under these conditions. However, it's about understanding the child for us and understanding what makes them feel safe, what potentially is also in the interaction with the parents that definitely is well intended, but not supporting a change in this behavior. And then it's about really finding the pattern and looking for the change. And this is what Lily said about trying different things, meaning let's really try it. And if one thing doesn't work, let's not linger on it. Let's try something new because, and I do think that also makes our approach. We are doing this for 30 years and have helped thousands of kids. And we would say we don't know how it works because every child has their own individual story. And this every child being an individual makes it much more interesting for us. And to interact with the family is so important. So that should give you a little context. And now, please, if you have brought any questions or if what we have told you is bringing up some questions, feel free to ask. Yes.
Hello, sorry. My laptop died halfway through, Lily, as well. I'm really sorry. I had to run and get my charger. If you saw me whizzing around, that's why. From the presentation you did, I was just curious about the videos. Are they kind of like to gauge personality of, well, in this case, my son, or is it actually videos of him with food, kind of, and what we do already?
Well, we will ask you to make different videos. So we have a standard that, especially, does your child have a tube or no tube?
He's completely tube fed since birth,
Okay.
so never
Okay.
eaten.
So normally the kids who start, they don't eat or drink anything while they are completely tube fed. So
Yeah.
the first phase of tube weaning is finding a feeding technique which works for your child. And this is probably, I find, the hardest. And depending on the oral aversion and on the oral developmental status they are, it takes a various time. So some children really get it in a week and we find something, and some kids do need a little bit longer. But we will ask you, especially in the first few weeks, to upload us 2 or 3 videos, which can be really short, so like 10 seconds, so that we get an impression, where is he, who is he, and what we can think of can help him, and which circumstances can we optimize. So it's about positioning is a very important thing. Texture of food, taste of the food, consistency of the food, atmosphere of the food, and so on and so on. So we will like slowly start to give advice to try different things out, what can make it easier for your son to make a little step forward. Because to start eating, for most people, it's like the most natural thing. So it's just like putting something in the mouth and then it will drop in your stomach. But it's not. It's like if you think of a child walking, it's the same, like kind of many thousands, I sometimes say 1,000 little steps until a child is walking. And it's very similar with the eating development. So until a child can eat a schnitzel with pommes, it's like 1,000 steps in between. So we
Yeah.
always have a very close look, where is your child at the moment, and our goal is always to make progress. And as long as we make progress, no matter how long it takes, we are happy because it goes forward. And we do have children, of course. It's impossible that children, or no, not impossible, but most children, if they undergo tube weaning and we are successful, let's say we have a 2.5-year-old child which has been tube fed since birth and then is able to live orally and like transit to all foods. He won't eat like a normal 2.5-year-old child. So this is an unrealistic expectations. But our goal is, can he sustain himself with his oral nutrition by drinking or eating whatever? So we really find out, and we never know in the beginning, will this child, because sometimes like the head is much older than the oral development. So we always have to find compromises. There are like children who want real food, but they're not able to eat real food yet. So
Yeah.
this is a kind of ambivalence which we need to solve with compromises. And that's what we do in this very intensive coaching over weeks, to see how does he get on. That's our main. And then he will always, if there is, like all the children learn at some point, they learn to it's not always eating, but at least or drinking or eating solids. So we always have to see. But at the end, it's only a question of time.
Okay.
So
And
the
I have
videos, we will ask you for specific videos.
Yeah.
And if you as a mother have the feeling, oh, I want to show them this, you can always send us whatever you want.
Okay.
I have the thankful job of after the answer has been given at 100% satisfaction, I can just mince a little extra in there. I want to add two little things. One is also concerning tube children, how the reduction works. This is definitely the most medical and detail-oriented approach in this first phase, where we ask you to reduce the intake via tube, and then we see to develop that hunger. And this is so closely supervised because if that hunger and therefore oral intake or other types of intake won't materialize itself, one needs to go up with the tube again. And here is really where our experience in the net coaching program shines through, because that's a dance. And that's a dance where not only this child needs to be safe, but moreover, the mother needs to feel like she's not
Feel safe and
completely,
always needs to know what to do if. What
yes,
am I doing if my child has
yes,
fever? What am I doing if my child looks too tired? And that's exactly why we need this intense contact.
to
And
really hold the
yeah.
hand.
And
And then
also
this,
we have children with heart diseases. We have children with medication, which they need more water than other kids. We have children with kidney disease. So we do have different medical, we get children from all apartments. So from metabolic disease to the most common groups are premature babies and children with a genetic disorder. And then it's like one third, and the other third is really a mix of the whole pediatrics you can imagine. So we always look exactly what does the child need and what is the minimum amount which is safe. Because I want to say something, Aaron, you said we want hunger, and many mothers fear that the children will not starve, but like be too hungry. And I'm always saying that, yes, we need hunger as a motor, but if your child is too hungry, we call it hangry, he or she won't be able to make progress, because then we lose the child, because the child will get very frustrated because he or she doesn't know yet what to do to solve this problem of bad feeling in the body. So we need to reduce it to a safe minimum, and we adapt sometimes the plan every second day or every day if needed, to really find the ideal tube amount and times and content that the
Yeah.
child is hungry and interested, but not too hungry and frustrated. And that's the tricky part.
Yeah. My fear, particularly with my son, because he's never eaten orally, is almost that he doesn't know what that hunger cue is. And I don't know how to teach him that, to
we
make that first.
Yeah, exactly. How could he? He
yeah,
has never
needed
experienced
to.
that
Yeah.
feeling, probably. So uh, even a newborn healthy baby on the first day of life starts to regulate, cries, gets the breast or the bottle, and there is a kind of regulation which the child also can be part of. But with tube-fed children, it's 100% control, times, amounts, and the content. And I'm always saying the only thing what a child is able to do to interact here in this feeding issue is to vomit. This is
Mm,
the only thing where the child can also regulate and say, "Oh, it's too much," and
yeah.
vomit. And most children we treat vomit a lot,
Yeah.
and that's the typical problem of too much by tube, and this vomiting problem and nausea, and also this just retching
Mm.
always disappears in 90%. Always is getting less or disappears.
Before we move to the last question, Helen, I want to tell you that we had a lot of patients that have never experienced hunger before. And to find that feeling and
Yeah.
then know what it means.
Yeah.
Yeah, this is a part of that first phase. And also for you particularly, and I'll maybe mention this at the end again, but if you have very specific my son questions, There, I would recommend doing a free evaluation with our team where it's a one-on-one call and you can really get in and ask in even more detail.
That would be
I
great.
will take the question from the Zoom user for a second.
Yeah.
Zoom user, hi. Please could you clarify how net coaching differs from eating school? How do you deal with safe swallowing eating, oral aversions over video call? How do you deal with building oral motor skills to teach to swallow, eat, and drink? Before Lily, you answer the net coaching part, I want to say in eating school how we do it for a second so that everybody can understand what the opposite is then. Really, we deal with it the same way. We change things and then we see what's possible. And then we try those routes through our experienced experts that we have in the team. And then we see what kind of skills are there. Even in eating schools, which are a 11-day, 2-week intense course, it is not the time to take long-term logopedic or any type of physiotherapy approach to learning entirely new skills. So there in eating schools, it's the same as already was mentioned. How can that child be fed? How will they accept the food? And Lily said before, we're not always trying to focus on the result. It's that next step in the development. So also in eating school, if somebody comes and say, I want my child to eat schnitzel and pommes, we will rather say, what is he eating now? Oh, only vanilla pudding. Let's try to end at vanilla pudding with specs because the next step is the only thing that we can reach. And coming off that is a challenge to the parents. Lily, you will answer the net coaching and
I will
then
answer the
Alice.
question for the safe swallow because this is
Yeah, and
probably,
then I'll get
as
to
I
you,
hear the
Alice.
question. Is that okay, Alice?
Yeah, sure, that's fine.
Okay, so the safe swallow is a very medical question. So which children, or let's put it that way, there is only a certain group of patients where we have a reason to think that the child has unsafe swallow. Unsafe swallow means that food goes not in the esophagus, gets in the wrong pipe through because of a dysphagia, that the muscles don't work because it needs 28 different muscle pairs that something can be swallowed safely. So if it gets in the wrong pipe, it goes in the lung. And then food will go to the lung, and then we call it aspiration. And this is very dangerous for children. So we see, and normally aspiration does only occur in children with severe neurological impairment. So we see in the assessment already, is this child high risk for unsafe swallow? Then we would probably ask you to make a swallowing test before. If there is no medical reason why this child should have an unsafe swallowing, we would not ask for diagnostics before, because the find out whether your child has unsafe or safe swallow is not an easy question to answer. There are special diagnostic features, but they have to be done in a very certain way, in a very perfect way, to have a good result which you can build on. Most cases, the child needs to eat something to test if the swallowing is safe. And most kids who come to us, they would not eat in this examination. So you can't tell. They will just scream, and then you can't say, is it a safe swallowing or not? So this question is a very important one. And actually, the children with really unsafe swallow, which are, I don't know, 0.5% of the patients who reach out to us, we would try to find out before treatment. And in some cases, we will have now a new program that we will have like a testing phase from 3 to 4 weeks to find out, is swallowing really safe? So this we can also find on the telemedical approach by looking at the videos very closely, hearing what you say as parents. Does he cough? Does he have pneumonia very often? So there are different ways to find out, or different hints, which makes unsafe swallowing likely, but most kids don't have a risk for aspiration and unsafe swallowing. So I would only expect it in children with severe neurological impairment which are in a wheelchair or can't move themselves, and they have like motoric problems all over the body, and then this part is also affected. So dear Zoom user, I'm sorry, I don't know a name, but if you have a question which is a little bit more specific, I think you could go for a written answer, question one more, or maybe you write and then we go next to Alice.
We'll come back to you.
I
Yes.
hope I got your point. Otherwise, please make a more specific question because it was 3 or 4 questions. So I'm
Yeah.
not sure if we really targeted your question
And the
correctly.
last point to this question is that we have a physiotherapist on the team, Eva Kershichnik, also a Costilla Morales therapist, and she saw about every swallowing issue you can possibly imagine over her time. And so even though we are over Zoom, the combination of the medical history of a child, usually they're in already great hands, and her experience will really make it possible to intervene through video call. Alice, please.
Hi, I've been at the eating school in May with Jessie,
Yes.
so I am here we are like, how is it different? So that's what
Oh,
I'm
wonderful.
finding out because
Yeah,
we are very happy so far.
great.
Jessie said thank you for all the good schnitzels.
Very good.
Um, the thing that we found out at the eating school is that he always wanted to sit on our lap with eating, which was comforting for him. But on the videos, it was not present. So how could you struggle those things, like
Mhm.
tackle those things when you're at home and you don't see them?
I don't understand the question. So it's hard to make a video while Jessie's on your lap? Was that a question?
No,
No.
we made videos during the intake and before we
Mhm.
started at the eating school.
Mhm.
At the eating school, it was visible that Jessie always wanted
Okay.
to
So
sit
you
on our
found out,
lap.
so you're saying you needed the eating school to find out a better positioning which works for your child.
Yes, correct.
Okay. But this we could find out in the telemedical approach as well, because we would say try to put him on put in your lap, put the camera before you feed him somewhere that he's not distracted, and try out. So we are always, that's what we said in the beginning. We never know the solution in the beginning. It's not that you come with your child and then I'll say, okay, this puree, this position, this. This is not, your child is unique.
Mhm.
And so this would be something, sit close to him, try to put him on your lap, this we very often also find out with the telemedical approach because we will ask for videos like almost every single day. So, and we always concentrate on what works well for your child.
And this is also added to Helen's question still. Of course, the eating interaction, the food intake, Helen, once we're at that stage of the program, that's where a lot of the magic lies after all the medical magic. And so in this case, if I think it's an interesting question because there are certainly limitations where we would have to make sure, oh, are we seeing everything? And certainly in eating school in life, you see certain
More.
things easier. I think what's better online is that we see specifically you in your natural habitat. In the eating school, as you know, Alice, there's so much
Yeah.
going on. There's so many children. There's all the issues at the same time in the room. And in the telemedical approach, you don't have that group boost, which is a great thing about eating school,
Mm.
but you do have that Zoom potential. Much better, I
So
would even say.
yeah,
More
it
one-on-one.
has advantages and disadvantages
Yeah.
because if you have a child
Yeah.
which is very sensitive to many people, he might be in an eating school, he would be overwhelmed. So it's much easier the telemedical approach because it's like normal circumstances. And um,
Yeah.
so we often sometimes ask mom to try the what is Kinderwagen, the Bram, and try the different seat and try this. So the positioning, I
It's big.
always think it's underestimated because the positioning is important.
Mhm. And
Yeah, I
maybe,
think both have benefits there at the eating school and back at home. I think they both
yes.
have their benefits, but we were like,
Exactly.
how are they gonna tackle that?
Yeah.
Yeah.
If you want to
Yeah.
sit on our lap and you will never
Yeah.
see it. But
Yeah.
yeah.
Since Alice, we have a lot of experience with the tube weaning online already. So I'm doing nothing else than tube weaning online.
Mhm.
So we do have a lot of good techniques already how to
Engage also.
make it possible.
Yeah.
Yeah.
Mhm. And then, Alice, maybe you could have you taken part of also the aftercare program after you've been to eating school?
Yes, we have also been taking care of the after program. For how long was it? Till July, I
Months.
think.
Yeah.
And
Yeah.
then the ticket system was closed.
Yeah.
Our son did not have a tube.
Mhm.
I've been in contact with a family with a baby that had a tube, and she's also off the tube now.
Mhm. Wonderful. That's great to hear.
So yeah, there's
That's
hope.
That's wonderful to hear. And also, this is part of our programs. Lily hasn't discussed it with the programs, but once you're done and a program lasts about 3 months, there is an aftercare program, which is just how is it developing, how is it continuing, and then also because some of our children they take a huge leap and then they fall back maybe due to a medical emergency, due to something, and then there is always possibilities to continue and make the next step. The Zoom user, thank you. You
Yes.
answered that very well. I'm just concerned because as she has facial palsy on one side of her face and floppy tissue on one
Mm-hmm.
side.
Mm-hmm.
Yes, Lily.
How
Does
old?
this give you
How old is your
medical?
daughter?
Yes, Mr. or Mrs. Zoom user, you could use the microphone and or camera. You would make our life a little easier. 1.5 years. Perfect.
1.5 is it? And on the tube and oral 0
Never
so far.
swallowed. Doesn't
Never
seem
swallowed.
like it.
Okay. The most
Yes.
important question in this case would be, or the most interesting for me, is your daughter able to swallow her saliva?
Hmm. One can only imagine. Yes. Great.
Yeah, I can see it as well, but also
Yeah.
drools a lot. Okay, so the drooling is sometimes hard to interpret it since every child with teething also drools in some cases. So, but is the pillow in the night completely wet or is it completely dry while she sleeps?
Lily, you're making this an interview.
Yes.
It's dry. Great.
Perfect. So this means that your daughter is able to swallow her saliva. So this would qualify her to try which consistency she would be able to drink or eat. So if swallowing is an issue, it's very often a question of consistency. And this we would like to find out with you together, if she can build up on her oral skills and is able to swallow. So normally the rule is the thinner the consistency, like water is the hardest, and like solids, period, food, like not apple mousse, but a little bit more thicker, would
Potato
be the
mash,
easiest.
like a potato
Yeah,
mash.
not, no, this is a little bit too sticky,
Mm-hmm.
like a little bit, yeah. So we would need to find out, but I would
Differently.
welcome you to make a free evaluation because sometimes, and then probably we would need a good assessment of your daughter to see, let's try it. In some children, the only ways that we have to try to find out.
Yes. Thank you very much. And lastly, I want to say to you, Mr. and Mrs. Zoom user, that also the concern of the parent is part of our program. So here in your answer, you've written part of the medical issue, and that is obviously in the focus. And then the concern of the parents in a lot of what I've heard in other therapy programs, they're like, no need to be worried, we got it, wait outside sort of deal. We know you don't. And we don't work like that. We think that the parents are the most important alliances and also people who are in charge of feeding that baby. This is why they are suffering because of that responsibility. So we also have therapeutic one-on-one potentials. We have therapists in our team. We have also coming next year, we're going to have group sessions where the parents share their experiences and what they've maybe also gone through. So there's a very much a side of being attentive to what the parents are concerning themselves with and not pushing that aside because it's just as important for the child to feel safety. They can only do that once they feel their parents feeling safety. Donna, please.
Hi, good morning and your evening. I am joining from Alaska. I don't know a lot about NoTube. This is kind of new to me. Resources here in Alaska are pretty, there are not a lot of them. And I work in an early intervention program. We have about 300 children altogether enrolled. And it seems like more and more babies are coming to us with tubes. I have a few on my caseload. There's a lot of them. I have some logistical questions, and I also have a specific case question. So one, how does it work internationally with the billing and payment?
It works great. It just works great. Donna, it works. We have, especially in our telemedical approach, we are an international firm. The eating school that we are running till the end of this year is a local house, but we are international, which means we've had a lot of patients from the US, a lot of patients from Australia, a lot of patients from all over, and especially the patients from US. There, I've never heard any difficulties when it comes to these transactional organizational questions. Yes.
But I think Donna's question was the payment, right?
Right. Do the parents have to pay directly? Can they bill insurance?
Yeah. Well, Donna, the thing is that after this assessment I was talking about, when we say this child is suitable, the families get Unterlagen. They get
documents
to give their insurance to ask if they pay it. But
Okay.
it's not.
So they would be reimbursed.
Well, the insurance company will tell you yes or no, or maybe. So the parents need to try to get the money from the insurance company, and some parents decide, well, we go for it and we find the money elsewhere and we wait for the insurance to pay afterwards. And some families just say, okay, let's wait for the insurance. So there are different countries, and there are also some parents who crowdfunding to get the money quite quickly. So there are different ways, but it's not that we can promise you that every insurance company will just pay the price for the net coaching. And I think what you said, that more children with tube, especially babies, are discharged, is mostly the reason that the time of duration of the hospital stay is getting shorter and shorter because of different money reasons. So many premature babies who could probably, if they stay 2 or 3 or 4 weeks longer in hospital, they probably would be able to transit to oral feeds and can be discharged without the tube. But since we have many problems also with personnel, like shortage of nurses and so on, sometimes the kids get discharged and then no one is taking care of this oral development and they kind of get stuck on the tube. So we do have children who could have probably weaned quite easily, like in the first step, but then they're on the tube and then things go and tube dependence develop, which means that they vomit, they are completely full all the time, so they have no motor. So this is kind of problem we see all over the world, that parents are often quite alone with children with tube fed children, and there are not so many specialists really specialized on tube weaning. And this is what makes us unique, because that's like our main focus the last years is really tube weaning, and it doesn't matter which tube, like transitioning, and we do have a concept. And some doctors, it's not that often that they really have a concept. And we don't have the capacities to really be in contact with the family every day, because if you are in this transition phase, it's hard if you say parents, okay, let's see it next week. If you have a baby which just get off the tube and then you have to decide, or is this intake just enough or not? So this needs really a lot of capacities.
And I think
so
also
maybe one thing, so we are in English and German. So the requirements the families need to have is speaking English, having internet all the time, and they need to go to the finance process first. So we can only start the treatment when we have the money.
If we had families here, so we're a home visiting program, would it be okay for one of our providers to be with the family while they're having their telemedical?
Of course, we would be happy to collaborate. Of course.
Okay. And then I had a specific question. So this is a child that I see on my caseload who he has some genetic things going on. He also likely has an autism diagnosis. He's just 2. He's been on a tube since he was born. He has zero interest in anything. And his mom also has her own feeding issues and will not like we can't get to the child. We can't get sensory play to the child because of the mom's own like she lives on Red Bull drinks and that's essentially all she drinks. So any ideas of how to approach that?
Is the mother suffering from the tube dependency of her son?
I think she would like him to stay on the tube forever because she doesn't want to deal anything with the mess of having to present the food, the waste of the money
Well,
if she makes something and he doesn't eat.
we do know that there are some children, many on the world, where when the parents, mostly the medical system, does not push parents to the tube weaning because you have 100% control, everyone is happy, apart from the child probably, who would be maybe able to eat. But if parents have
Suffering motivation.
no suffering motivation, it's impossible for us to do anything.
She wants somebody
So,
else to do it. She would like us to do it in the 1 hour where we're there out of the whole week.
but
Yeah.
feeding your child is one of the most important things a mother has to do. This is the Pflicht,
Duty.
the duty of a mother. And the only thing you can say as a professional is we think every child deserves to learn how to eat if it's possible. And this is part of the deal. And we think that your child is able to learn how to eat, and we would like to give him a chance. Maybe I would probably ask her why it feels so comfortable for her, or why, like,
I
but
would
if
also
she has
ask,
no motivation, I think it's
yeah,
impossible.
I think it's the long run that needs to be highlighted to that mother. Where should this go? Because as this the same reason as the medical institutions who release children with tubes that don't need tubes is because it's not their problem. And now the parents, we even had some patients where on the surface level, all they want is their child to get rid of the tube. But when you are at that point where it's either tube or a lot of work for the parents, we're talking about
Feeding
little
every two
children
hours and
and,
finding
and,
out,
and
and
feeding for 2 hours straight. We're talking about children who can take minimal intake, children who have muscle issues that don't allow them to have a comfortable position for the parents. So really for some parents, it is an incredible amount of work they're getting once the tube is out. And I think here really I would ask the mother, where is this child in 10 years?
does the child have a G tube already, or is a nasogastral tube?
It's a G tube.
Oh, that's too easy.
It's
Well,
slow
I would
feed with a
maybe
backpack.
say, yeah, I would probably say, what are the advantages and what are the disadvantages?
Yeah. And Donna, lastly,
Go
on
to
your question of also cooperation, please write us an email from your institution with your institution. We can there really talk about and think about how we can, since your institution seems to be with limited resources and a lot of kids who need this help, we can also think about maybe some training programs for your team. And we can think about certain cooperations. What I always think with our American patients is in America, you pay one medical bill and then it just blooms and you don't know what to do. We have a European product, which means it has one price. There's no hidden fees, and you pay that one thing, which is manageable insofar as it's at least controllable. And there, I think the American medical system is, I mean, not to get sidetracked, but different. Lily, and then we'll move to the next question.
yeah, one last sentence. The thing is, imagine a mother who wants medication for the child, which the medical team doesn't think it's indicated anymore. Let's say a child would get sedativa to sleep, and then the mother would just keep doing it, but then the doctors and the nurses and the team think that it's not medically indicated anymore. Because I'm thinking, who is placing the tube and who is paying for the drinks, the tube milk? So this is quite a big cost factor compared to normal food. So if your team is really convinced I mean, in some children with autism, it is really hard, and we can't promise you that this child will be off the tube. I don't know the child, but if your team really thinks this child will be able to eat with professional help, then one has to say, okay, we can't support the tube feeding longer because we think it's not necessary anymore. What your child needs is a professional tube weaning trial. This is probably the way I would argue.
Okay, thank you.
Alice, please.
Can I react to
Please.
that? Because
Please.
in the Netherlands, like the insurance didn't pay. So we got to the city hall because he's under 18. They have the obligation to take care of him. And we said he can go to the Netherlands for 6 months, but then it will be 60,000 euros. Or we can go with the entire family to the eating school, which is only, what was it, like 11,000 in total. So which option do you choose as a city hall? And they said, okay, we support you with the money because it's cheaper compared to 6 months in the Netherlands for 60,000 euros.
Yeah. Yeah. It's a lot cheaper. What we've heard, stories from Germany, Donna, where children are being put in psychiatric stationary care for 3 months because they can't eat, they can't seem to widen their palate of food. And now ask yourself, and I think we can all know the answer to that, what happens to an already scared child if you put him 3 months in a mental ward with no issues other than a very, very small palate of food intake? And so what we see a lot, and a lot of the patients that actually do come to us are patients that have been frustrated and disappointed with local services and offerings with their tube, parents who have tried everything, don't feel supported, not saying we do everything right, but we do it our way and we take you seriously.
Yeah. And I think most of our patients, especially in the net coaching program in the tube dependent children, they have been in hospital almost
most of
half their life or even longer, especially children with heart problems. So they have been living on intensive care longer. So the parents say, we can't, if there is another option than going to hospital for another few weeks or months, we would always choose the home-based treatment because it has so many disadvantages also for families. There are siblings sometimes. So one always has to make a balance. Is it worth it? And in Germany, it's the every insurance company pays every hospital in Germany to do for weeks and months tube weaning program if it's successful or not. But most of them, they are not so generous to pay our net coaching in the first place. But often if we explain a lot and the parents really fight for it, very often we do get also a positive answer from the insurance.
We are in the beautiful country of Austria, Donna, which is Germany, but better, as I like to say. Just cuter, just smaller. And here we are, and here's our telemedical. Also, my Lily does now work in Germany, but we're an Austrian-based company. And before we were having an eating school, we already did the telemedical approach. So really, this is more tested. It's just the eating school is much more intuitive because it reminds people of a very classic setting. Lastly, Donna, I am dropping you my email address in the chat because please reach out, especially in this institutional cooperation. We also have one physician working for us, Marion Russell. She works in Omaha and at what's the university called? Brandeis? No, not quite. Creighton University. Yes. And she's an associate professor at Creighton. And so we do have good ties to America where we could potentially connect you with better resources that we can today if we connect you to Dr. Russell.
We have a lot of occupational therapists from Creighton University.
Well, so small
probably
is
they
the
know
world.
her. Marion Russell is her name.
Yes.
She's one of our feeding specialists in the team.
That's how we made one connection from Alaska to Austria. We come to the last 10 minutes of our evening. Lynn, welcome. Did you bring any questions with you tonight? No,
You look
just
like
here
a
to listen.
professional, but maybe also just a mother working still.
No, I'm
As she is.
early intervention OT on the West
Yes.
Coast of Canada.
Oh, no, we can't hear you. Okay.
Wonderful. Welcome. And glad to have you here. Well, then I open the floor. Also, Luz Carasa. If there are any more questions, I'll just open the floor. We wait, and if there are no questions anymore, then we'll just close it for tonight. If they are, we're Glad to answer them. Hi, Mascarasa. Microphone, and then we're excited to answer your question.
Okay, sorry.
Thank you.
Yeah, if you have a little bit of time, if you could talk a little bit about oral aversions and how you tackle that, because my kid is eating orally, she's just not feeding herself, she's not putting food in her mouth. I have to feed her with a spoon.
How old is she?
She is 3.
How much is she
And
eating? Variety?
She had a NG tube for the first 6 months of life. She was born with a cleft palate. And she's eating how much, like, you mean like the variety of foods? Or she's eating a good variety of food, but she's not eating like big chunks, like she's chewing. So
it
it's
has
more
to be
like,
blended solids.
no, it's more like fried rice or like a little mac and cheese with pasta really small. So she kind of chews a little bit, but she won't grab a banana and bite it
And a
and chew.
banana is a hard thing. So it sounds, we would call this an eating developmental delay, which is very typical for cleft palate, tube feed history, and then she kind of is a little bit slower. I don't know how she's in other fields, like from a
She's
motoric.
slower in everything.
Slower, yeah.
Yeah. And
So
I
this
also
is
have to say that she had a really bad oral aversion when she was little. Like you couldn't even touch her mouth. All the like chewing that kids do with toys and things like that. She's now starting to do that. But this is kind of like a recent thing. So we've worked really hard. Although you've saying about parents working really hard, it's like, oh yeah, this
Yeah.
has been a journey.
That's
Yeah.
you, yeah. But the good thing in a telemedical approach is that the parents work hard, but they are also rewarded the best because then you do the job and not a therapist is able to feed your child. So this is always also something which feels very rewarding for the parents and also for me if we just give advice how to help the child. So the oral aversion, I would say there's not one child in our treatment who does not suffer from oral aversion, but oral aversion is also a spectrum. Children, there are children when they see food, they start vomiting and retching, and children who have a less severe kind of oral aversion. So we would probably always work on what does she like and what works well already, and then we start in small steps to encourage her to eat more. Depending on her weight and so on, we have different ways of how hard we push it. Because if you would tell me your daughter is already on the, or I would calculate her growth data and she would be very, very close, we would be, of course, we wouldn't have as much Spielraum. The frame would be a little bit more narrow. But I think what could be interesting for you is our Learn to Eat program. So if you book a free evaluation with Eva Kashishnik, which is our feeding therapist and the leading therapist in the Learn to Eat program, you would talk to her every week, and I'm also in the background, to really discuss what can we change to get a change in her, that she can make progress. So this would be a very typical case of oral developmental delay, which can be treated very well, actually. We do have many patients or parents who are very happy what is able to reach in 3 months. If you do a very focused one-to-one changes, because sometimes one as a mother, and I know it as well, I'm also a mother, you're kind of stuck in the world you are living and the way you do it and the foods you offer and the way she sits and the way. So sometimes it's good to get new impulses and try new things. So I would invite you to get a free evaluation with Eva, Eva Kashishnik, and all the Learn to Eat programs we have, I get the feedback of the parents that they benefited a lot from that. So we would
And
always make
also,
it.
I have one more question, and is that how do you integrate this with the schools? Because she goes
For the
to
schools.
school.
Well, it depends what the school is ready to, how much capacities they have. So, and also depending on how many hours your daughter is there. So probably we would start with home-based with you first, and then you would give them and say, okay, she can have that, and I don't know which food she gets there. So we try to find a way, and if it's needed, we sometimes also have a Zoom call with the kindergarten and ask what potential do they see to help us or no, help your daughter to make the next steps.
Yep. And then I want to, Luz, thank you very much for your question. I want to also add something on food aversions because I think this is interesting for everybody, not concerning your particular problem, but the food aversion in general. Um, One of our team always says for grown-ups to really think about it is for a child who hasn't eaten a certain food yet and is afraid of that, it's like putting a snail on your plate and then saying, here, how about that snail? And so it's
It's
really
so
this.
nice. Try.
Yeah. And then
Just have a try.
mommy loves the snail. It's not gross at all. And I think this really displays it well. It's that feeling of safety where, as you said, as you are stuck in this family interaction, you also know what works and what doesn't. But it's really difficult to say how comfortable a child is feeling in the food situation. And then there's also this thing that I have observed with our patients a lot, where it's like if they don't have to change, and it is more comfortable for them, then they won't really. They need to have some incentive. And the incentive that the parent would feel better if they would eat is not enough motivation. And so here it's this sort of like, what can we change very slowly and gradually to make everybody, you and the child, very safe during those new challenging steps?
And Luz, our main focus of our therapy is to increase autonomy of your child. Because this is something every child needs autonomy, and we would really try to increase it and like push it. And whatever a child is able to do by himself or herself, it's more likely that he will do it or she will do it because this is like a central need of all of us to the self-autonomy. So this is like the main key, probably increasing self-autonomy.
Yeah. And thank you all very much. Thank you also, Alice, for giving us this sort of inside perspective and giving also the other interested people an experienced already version. And thank you very much for your kind feedback, Alice. Also, I want to just highlight once more that the recording today is going to be on YouTube. Don't worry, nobody really watches it. That's my problem, not yours. But it's going to be on YouTube. It's going to be sent to you. Thank you very much for the Q&A. Our colleague has already dropped in the link for the free evaluations. Also, if you don't want to do those, send us an email. Don't be shy. And maybe we can help your child take the next step in their eating development. Have a wonderful evening or day.
Thank
Bye.
Thank
you.
you.
Bye.
Bye bye.